So in this video we are going to talk about the obstructive pulmonary diseases. Obstructive pulmonary diseases are those diseases in which there is increase and the diseases will lead to increased resistance in inspiration and expiration. So there are four diseases that come under the heading of the obstructive pulmonary diseases: emphysema, chronic bronchitis, asthma, and bronchiectasis. So now starting from the emphysema. Emphysema is irreversible enlargement of the air spaces distal to the terminal bronchial, accompanied by the destruction of their walls. So talking about the pathogenesis of the disease, the smoking is the triggering factor and it induces the tissue damage, inflammation, and the oxidative damage. And talking about the genetic predisposition, in about 1% of the patients with emphysema, alpha-1 antitrypsin deficiency is seen. Alpha-1 antitrypsin helps in the inhibition of the proteases, and the proteases cleave the elastase, which is the essential component of the lung tissue. So there is less inhibition of the protease in case of alpha-1 antitrypsin deficiency. So as a result, a lot of elastic fibers in the lung tissue, they are destroyed, and pan-phenotype of the alpha-1 of the emphysema is seen with the alpha-1 antitrypsin deficiency, and as it is a genetic predisposition, it rather starts early, and the disease severity also is also greater. So now talking about the pathophysiology. So in case of the emphysema, the problem seems to be with expiration rather than inspiration, because in the process of expiration depends upon the elastic recoil of the acinus and the lung. So whenever the elastic tissue is destroyed, the expiration cannot occur as properly as it should. So there is the barrel chesting due to the entrapment of the air, and the diffusing capacity of the lung is also reduced. As the alveoli, they are enlarged and the alveolar tissue are also destroyed. The alveoli are responsible for increasing the surface area. So whenever the alveolar tissue are destroyed and the air spaces become larger, it reduces the surface area of the lung and the diffusing capacity is reduced. In the regions where the lung tissue is destroyed, there is more ventilation, but the blood flow in that region is reduced, giving the resemblance of the physiological dead space. And in the region where there is the normal part, the perfusion is shunted to that region, but the ventilation is not enough so that it can ventilate the whole shunted perfusion. As a result, there is physiological shunting in the normal area of the lung, and there is physiological dead space in the region where the lung tissue has been destroyed, and extremes of the BQ mismatch can be seen. So as a result of BQ mismatch, we can see hypoxia and hypercapnia. So due to which there is increased breathing rate for the compensation, and the patient sits in a hunched over position and breathes through the pursed lips. So they are also called the pink puffers. And also due to the hypoxia, the pulmonary arterioles, they are sensitive to the hypoxia, and they will undergo vasoconstriction. As a result, we can see the pulmonary hypertension, and in the long run the pulmonary hypertension will lead to the heart failure, which is also seen in chronic bronchitis, which is also due to the same mechanism of hypoxia leading to pulmonary hypertension and right heart failure. So now talking about the types of emphysema, there are four types. Centriacinar. The centriacinar is the most common type, and it is associated with smoking and involves the upper lobes. So moving on to the diagram, in the diagram we can see the part of the airway that is distal to the terminal bronchial, which is also called the acinus or the respiratory unit. So if which is further divided into respiratory bronchial, alveolar duct, and the alveolus. If the proximal part of the acinus is enlarged, then that is called the centriacinar emphysema, in which the respiratory bronchial is enlarged. And if the alveolus is enlarged, then it is called paraseptal. The distal part of the lung is enlarged, then it is called paraseptal. And if the whole part of the respiratory unit it is enlarged, then it is called panacinar. And there is also a pattern in which in some regions of the respiratory unit you can see enlargement of some regions, and in other you can see enlargement of other regions, and that is called the irregular emphysema. So now Panacinotype is associated with alpha-1 antitrypsin deficiency, and it occurs in the lower lobes. And the paraseptal one, it is there is the involvement of the lung adjacent to the pleura, and it is associated with smoking and can lead to spontaneous pneumothorax. Irregular one, as already discussed, it can occur with various forms of emphysema occurring in the different acinas. So and it is also associated with fibrosis. And other than the types of emphysema, we can also find different forms of emphysema. So compensatory hyperinflation. What happens in this case is that whenever a person undergoes lung rejection, to compensate for the part of the lung rejection, the remaining part of the lung undergoes hyperinflation. This is compensatory hyperinflation. Another is obstructive overinflation. So whenever there is obstruction in the airways in such a way that the air can go in but the air cannot go out, then that leads to a condition of obstructive hyperinflation, and the air entrapment can be so severe that it can create an emergency condition, as the air entrapped in that region might compress the whole part of the lung. And the next is bullous emphysema, in which the ear trapped, the size of the bulla becomes greater than 1 centimeter or greater. And in case of the interstitial emphysema, the alveolus is ruptured, and the ear is has direct communication with the connective tissue of the lung. And the next obstructive pulmonary disease is chronic bronchitis. So chronic bronchitis is productive cough for 3 months for 2 consecutive years. So pathogenesis, in similar to emphysema, the initiating factor is smoking, which irritates the airways, resulting in mucus hypersecretion, and the mucus then leads to the obstruction of the airways. The inhalants also cause inflammation and cellular damage, and by chronic and the acute inflammation, and the infection rather plays a secondary role, and the role is in maintenance of the chronic bronchitis and in acute exacerbation rather than in causing the disease. So now the pathophysiology. Initially, there is hyperplasia of mucus glands and the goblet cells, and that leads to the luminal occlusion due to the reposition of mucus, which leads to hypoxia and hypercapnia. Due to hypoxia, the blood from the blood is shunted to the more important or the vital organs of the body, and there is cyanosis in the lips and the fingers. And also due to the hypoxia, there is pulmonary hypertension, which leads to right heart failure, due to which there is edema in the feet and the body. And they are called blue bloaters, blue in the sense that they are cyanotic, and bloaters in the sense that they are edematous due to the heart failure. And the chronic bronchitis, there is an important ratio to know, that is the reed index. Reed index is the ratio of the thickness of the mucus gland layer to the thickness of the wall between the epithelium and the cartilage. In a normal person, the ratio is 0.4, but in a person with the chronic bronchitis, the ratio is greater than 0.4. So the chronic bronchitis and the emphysema, they go hand in hand in a smoking person, in a smoker, and they ultimately lead to dyspnea and heart failure in the long run. And the person can be either predominantly emphysema declined, or declined towards the chronic bronchitis. So in case if he is declined towards the emphysema, then there will be the symptoms of the pink poppers, and if he is declined to the chronic bronchitis, then there will be the symptoms of the blue bloaters. So that concludes our topic on emphysema and chronic bronchitis, and in the next video we are going to discuss about asthma and bronchiectasis.